Good morning and welcome to the webinar. Our topic today is chronic mental illness and the risk for dementia. And these complimentary webinars are brought to you through a collaboration of sponsorship, Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And my name is Kim Bailey, and I am with Alzheimer's Orange County and will be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial for anyone who works for and cares for older adults. And we know that you will find today's presentation especially informative and useful. And now let me tell you a little bit about our esteemed presenter, and then you'll get to meet him and he'll take over the presentation. Dr. Art Woloschuk is a board-certified geriatric psychiatrist and professor of psychiatry at the University of Wisconsin School of Medicine and Public Health. Dr. Woloschuk is vice chair for education and faculty development in the Department of Psychiatry. He is past president of the American Association of Directors of Psychiatric Residency Training and currently serves on the Psychiatry Review Committee of the Accreditation Council for Graduate Medical Education. Dr. Woloschuk's research focuses on public health approaches to improving the care of people with dementia. He works with the Wisconsin Alzheimer's Disease Research Center, where he is co-leader of the Outreach, Recruitment, and Education Corps, and with the Wisconsin Alzheimer's Institute, where he leads the public health pillar. Dr. Woloschuk provides care to older adults with depression, anxiety, dementia, and other mental health conditions, and teaches other physicians to do the same. Thank you. And at this time, I'd like to ask Dr. Woloschuk to join us, and I'll turn things over to you. Thank you, Dr. Woloschuk.
Thank you. Thank you, Kim, for that very kind introduction. And of course, thank you for welcoming me. Thank you to Alzheimer's Orange County and to all the sponsors. I've just been really impressed with the level of interest in this topic, this overlap of chronic mental illness and dementia. My background is as a psychiatrist and as a geriatric psychiatrist. And as in both worlds, I take care of people who have chronic severe depression, who have bipolar illness, who have schizophrenia, all conditions we'll be talking about today. And of course, wearing my geriatric psychiatry hat, I also take care of people who develop dementia. And it turns out that the folks in the first category are more likely to also then develop dementia, become folks in that second category. And so as we see more people aging with chronic mental illness, there's been an increase in interest in this topic. So I'm delighted to share what I know on this topic, my experience in this area. And then also I greatly look forward to your questions as well. So here's our outline, kind of the big key messages from today. So I've kind of divided this webinar up into three portions. So the first takeaway is that people with mental illness and or alcohol use disorder do have a higher rate of dementia. In the second section, we'll talk about older adults with chronic mental illness who have changes in behavior or functioning. That should get us thinking about the possibility of dementia and should lead to an evaluation. In that section, I'll talk a little bit about suicide and suicide risk assessment as well. And then finally, in the third portion, we will talk about really a person-centered approach to helping people who have chronic mental illness who perhaps have developed dementia. And we'll talk about culturally sensitive approaches as well as trauma-informed care. And then in the last 15 minutes, we'll have time for some questions. So let me just start by defining some terms. When I'm referring to this relationship between chronic mental illness and dementia, what exactly is chronic mental illness? So for the purposes of today, I'm going to focus on 4 conditions, and these can overlap with each other. So I'm going to first talk about schizophrenia, and then bipolar disorder, and then major depressive disorder, and then alcohol use disorder. So for each of those, I'll just give you a little primer on what each of those is and what the relationship is between that illness and dementia. And then as we close this section, we'll talk about kind of what unites them, what might be the various reasons why people with one or more of these conditions may be more likely to develop dementia. So by way of background, kind of who are we talking about? How many folks are we actually talking about in the United States? So these are just some rough estimates based on what we know about the prevalence of each of these conditions and how many people there are in the US over 65. So there are roughly 270,000 people with schizophrenia in the US who are over 65, 320,000 with bipolar disorder, 1.2 million with major depression, and another 1.2 million with alcohol use disorder. So these are pretty significant populations. And bear in mind that these things can overlap with each other, especially alcohol use disorder with the first three conditions. So people with schizophrenia, with bipolar disorder, with major depression are more likely to have alcohol use disorder than people without those conditions. There are other substance-related conditions related to, say, opiates or stimulants like cocaine and amphetamines. We won't have time to talk about that today. Those pose their own problems with respect to cognition. Briefly, they're not really good for memory and cognition, but just for the purposes of time, I'm going to focus on alcohol as a substance that a lot of people use and that in many people can contribute to or cause cognitive impairment. So let me do a little bit of a deeper dive first on schizophrenia. So schizophrenia is a severe form of mental illness that affects roughly 1% of the population. And it really has kind of three sets of symptoms that go along with it. So there are things that we call positive symptoms. Those are things that are there that ought not to be there or usually aren't there. And those are things like hallucinations, where people see or hear things that aren't there, or delusions, where they believe things that are not likely to be true. There are negative symptoms, and those often cause people a lot of problems because those negative symptoms get in the way of forming relationships, of holding down a job, of having the motivation and the interest to follow through on plans. And so that could be a significant issue for many folks with schizophrenia. The thing I want to focus on, though, for today are the cognitive symptoms. So a lot of people with schizophrenia have difficulties with memory, with attention, with decision-making, and that actually starts fairly early on. So this graph to the right is kind of, it's meant to demonstrate that so over time, if you track the cognition, so just a global term for memory and attention and decision-making and so on, you would actually see that people's cognition starts to drop even before there's any clear evidence of schizophrenia. There's a phase called the prodrome, where people are starting to have a little bit of symptoms, but not quite meeting criteria for schizophrenia. People are already losing some cognition during that time. And during their first episode of psychosis, they lose even more cognition. It then plateaus out. But the point is that this plateau is lower than it would have been otherwise if the person did not have schizophrenia. So people with schizophrenia have a disadvantage from go in terms of cognition because of this hit that happens usually in teenage, late teens, early 20s is kind of the typical onset of schizophrenia. It's usually earlier in men than women. It's rarer later on to show up. So there's something called late onset schizophrenia, which is after age 40, and then very late onset after age 60. One critical issue to bear in mind with schizophrenia is that about 90% of people with schizophrenia smoke. And when they smoke a lot. You can have people smoking 2 to 4 packs a day. So very high amounts of nicotine. A lot of folks roll their own, so they're unfiltered, et cetera. So tremendously high levels of tobacco and nicotine. And of course, tobacco, as we know, is associated with all sorts of negative outcomes, including dementia. So that may be one of the linkages between schizophrenia and dementia. One other thing I wanted to highlight is that many people with schizophrenia have smaller social networks than people without schizophrenia, and their social networks tend to be made up more of professionals, healthcare and social services professionals. That's important because we know about the relationship between isolation and loneliness in later life and things like depression, anxiety, and cognitive impairment. So again, a lot of folks with schizophrenia may kind of have a disadvantage to begin with respect to cognition because they have these smaller social networks that tend to have more of a kind of service orientation to them rather than close friends and family. And so that can have some negative effects on their cognition. Now, this is a bit of a busy slide, so I'm going to walk you through it. I saw that question. About 90% of people with schizophrenia also smoke. This is a busy slide, but really the take-home message here is that people with schizophrenia have much higher rates of dementia than people without schizophrenia, and they get it much earlier in life. So let me walk you through. There are three curves along the bottom here. There's like this dark green one, then this teal one, and then this bronze one. So these are curves of people who do not have severe mental illness. And so by age, that's on the x-axis. On the y-axis, what percentage of people have dementia? And the three different curves are for three different racial and ethnic groups: Black, Hispanic, and not Hispanic white. And so you can see that, like, if you get to about age 85 or so, you've got about 20 to 28% of people have dementia in populations that don't have severe mental illness. If, however, you look at these top three curves, so these are people specifically with schizophrenia, again, Black, Hispanic, non-Hispanic white, you can see just going back here, age 66. So at age 66, it's the same proportion of people with schizophrenia have dementia as folks in their 80s who don't have schizophrenia. So essentially, schizophrenia advances the onset of dementia by about 20 years. And so overall, we kind of think of if you have schizophrenia, it's about a 3 times higher risk of developing dementia than if you don't. I mentioned smoking is one issue. We'll later talk about other reasons why this might be the case. Now into bipolar disorder. So this is another common severe mental illness. Again, probably roughly, there are different kinds of bipolar disorder. If you combine the main kinds, it's probably about 2% of the population has bipolar disorder. So this is characterized by extreme highs and lows in mood with good recovery in between. So a person may have a depressive episode and then recover, and then have a manic episode where they have tons of energy and don't sleep and do all sorts of impulsive things that can get them in trouble, and then good recovery in between. In general, there's some caveats to that. There are a lot of comorbidities, including alcohol use and other substances. Here's the caveat. So when people don't have symptoms, they're not manic, they're not depressed, they actually still have a little bit of cognitive impairment left over. If you're very depressed, that's not good for your cognition. It's hard to think, it's hard to make decisions, it's hard to remember. Same thing with if you're manic, you're easily distracted, your attention's all over the place. It's not good for cognition. But even in that baseline state, we call it euthymia, where you're not depressed or manic, you can have cognitive impairment. So in older adults, someone who has bipolar disorder and is euthymic, they actually have more cognitive impairment than in someone with a condition called MCI, or mild cognitive impairment. And then if you have bipolar disorder and you're an older adult and you're manic or depressed, you actually have greater cognitive impairment than a severe form of dementia called frontotemporal dementia. So bipolar disorder is not just a mood disorder, it actually has a pretty significant component as well. Interestingly, I've been telling you all bad news so far. There's some good news along the way. So lithium is the gold standard medication for bipolar disorder. Doesn't work for everybody, but it actually may have some cognitive benefits. So if you don't have bipolar disorder, no, don't start taking lithium. But if you do have bipolar disorder and it's an appropriate medication, then lithium can actually reduce the chances of dementia. It's not clear how or why that might be the case, but in folks with bipolar disorder, it seems like lithium might be protective against dementia. So here, this is sort of a similar curve to what I showed you. It's flipped the other way. This is a survival curve. And so what this means is that everybody on the left who's at 1.0 is free of dementia. And then as you go to the right, you get fewer, you have more and more people who do have dementia, or fewer people who are free of dementia. And so again, these curves this top curve is no severe mental illness. This is a veterans population, by the way. This like hash mark crosses, these are folks with bipolar, and then the X's are folks with schizophrenia. So bipolar is kind of intermediate in between schizophrenia and not having severe mental illness in terms of risk of developing dementia. So roughly bipolar disorder doubles the risk of developing dementia. Depression also, it turns out, increases the risk of dementia. Now, about half of people who have depression, a major depressive episode, will just have one episode and never have another episode again. But the other half may go on to have a more recurrent or even chronic course. So if you have one episode of depression, 50-50 chance you'll have a second. If you have two episodes, 75% chance you'll have a third. If you have three episodes, it's about a 90% chance you'll have a fourth. And then after that, it becomes a recurrent or chronic illness. And so especially if you've got more of that recurrent or chronic depression, that increases the risk of dementia. Now, there's a different population of folks with depression. There are folks who were not clinically depressed anywhere earlier on in their lives, and then after 65 have their first episode of major depression. Those folks, unfortunately, are at markedly higher risk of developing dementia. About half of them will have dementia within 5 years. And the thought is that in that category, those late onset depression, it's that the depression is actually an early signal that something is not quite right with the brain, that the person may be on a trajectory towards developing dementia due to Alzheimer's disease or vascular dementia or another kind of dementia. And so in both groups, the early and late onset, there's an increased risk, but especially in that late onset group, there's a much higher risk of developing dementia. Okay, so why? So if we tie together schizophrenia, bipolar disorder, major depression, why would all these conditions have higher rates of dementia? So one, tobacco, I mentioned already with schizophrenia. People with bipolar disorder also smoke more. People with depression smoke more. And tobacco has, markedly higher risk of dementia. Alcohol, we'll talk about in a minute. That's a bit of a more complicated story, but we'll cover that. And certainly other drugs, like if someone's using cocaine or opiates, that's going to have an impact on cognition. Many people with severe mental illness also have other medical conditions like diabetes, heart disease, high blood pressure, high cholesterol, and all of those can increase the risk of dementia. Many folks with chronic mental illness have difficulty with regular exercise, and exercise has a protective effect against dementia, so that might be a risk. I won't go through all of these, but basically there's a long list of reasons why these various conditions might be associated with increased risk. I will point out one other, and that's the poor access to medical care. So a lot of folks with mental illness, especially schizophrenia and other severe mental illness, really don't have great access to care. And that may be insurance reasons, that may be stigma, there may be racial, ethnic, LGBTQ, other sort of overlays that then result in people, running into structural racism or other things that interfere with their ability to receive care. So that's especially important. A lot of folks with severe mental illness just don't get like the usual health screenings and, checking out for colon cancer and heart disease and all the other usual preventative measures. And during the pandemic, all that got exacerbated quite a bit as well. And then finally, there's this concept of the lower cognitive reserve. I showed you that with schizophrenia, that many people with schizophrenia, they lose some cognition in their teens and 20s and don't recover that. And it's not really necessarily all that noticeable in early and middle life, but then it sort of starts you off at a lower point in later life. And so it puts you at higher risk for having cognitive decline. All right, let me talk about alcohol a little bit next. So this is a little more of a complicated story. Historically, there was some thought, and I'll show you this on the next slide, that maybe a little bit of alcohol use may be protective against cognitive impairment. I personally don't really think that's true, and I think there's a lot of evidence to the contrary. Certainly, starting alcohol use with the hopes that that'll help your cognition is not a good idea at all. I would definitely not recommend that. And anything beyond the usual guidelines around alcohol use is really going to increase the risk of dementia, which I'll show you in a curve in a minute. So first of all, what are the guidelines? So The National Institute, the NIAAA, recommends that for people over 65, no more than 3 drinks in a setting and no more than 7 drinks in a week. I think 3 in a setting is a lot personally for someone over 65, in particular if they have other medical or mental health issues, but these are the official guidelines and no more than 7 in a week. And then there's at-risk drinking, which interestingly actually sort of goes against the NIAAA definition, but 2 or more drinks on a usual drinking day in the past 30 days, and then binge drinking, which is clearly problematic, 5 or more drinks, at least one day in the past 30 days. So pretty high numbers. So 28% of men over 65 would meet one of those 2 criteria, and 11% of women over 65. Now, what is a drink? So the standard drink is 12 ounces of kind of regular strength beer, 5% beer, 7% of a stronger beer or malt liquor, 5 ounces of wine, or 1.5 ounces of alcohol. So that's what we mean by a drink. Then if you look over time, there have been a lot of studies that have followed people over time, looked at their drinking habits and seen what the risk is of dementia. And the way to read this is how many drinks a week a person has, and then what is the risk? That's what a hazard ratio is. What's the risk that someone's going to develop dementia? And so it's conceivable that there's some sweet spot of a little bit of alcohol use that might be okay, and less than that slightly increases your risk of dementia. Clearly to the right, I mean, the more you drink in excess of those recommendations, it's definitely going to raise risk. And why would that be? So alcohol is a neurotoxin. It kills brain cells, it kills nerves. And bad news, we're all losing brain cells like every single day. Like, boop, I probably just lost another 100 brain cells right there. That's just part of the normal aging process. And we don't want to accelerate that. And so I think, and certainly at anyone where there's any concern about cognitive impairment, where there's concern about falls, sedation, other medical issues, medications interacting with alcohol, we would advise against drinking or really keeping the alcohol use down to a minimum. So the take home for our first section here is that people with chronic mental illness and or alcohol use disorder have a higher risk of developing dementia. So just kind of raising awareness of that issue. Okay, let me go on to the next section. So now, so in folks who do have chronic mental illness, when might we begin to suspect that they may have dementia? So this list is actually not super different than in people who don't have chronic mental illness. So any new significant difficulties with remembering new information or recent events, repetitive conversation, so sort of asking the same thing over and over again or saying the same story over and over again, or word finding difficulties. We all have it. I just had it. I couldn't remember what the 3 A's and NIAAA stand for. I think if I thought about it, I could get to it, but I'm just going to move on and just call it NIAAA. So I had a little word finding difficulty there. So it's not uncommon, but if it starts to become significant and impairing day-to-day function, that would be a worry. Not recognizing folks that we ought to recognize. So this could be kids or grandkids. Some other change from baseline cognition, any change in personality or behavior should raise concerns, and then functional issues, meaning day-to-day life kinds of things. So especially like troubles driving, so like getting lost driving or having fender benders, or difficulties with money management, not paying bills, paying the same bill over and over again, et cetera, or other evidence of being able to take care of oneself. So it's kind of the same in people with severe mental illness than in people without severe mental illness. There are some challenges though. So because there may be some baseline cognitive impairment, like in schizophrenia, some of our usual screening tools, like I'll mention the MoCA or the Montreal Cognitive Assessment later, may not be quite as valid in this population. I would still go ahead and use them, but they may not be quite as clear in what they're saying about whether the person has cognitive impairment or not. We may not know what the person's baseline cognitive functioning is, and so it may be hard to say, well, is this really a change from before? This is where family or friends or social workers or others may be helpful. And then ultimately, as I mentioned earlier, a lot of folks with severe mental illness, especially schizophrenia and bipolar disorder, have poor access to medical care. So just getting in to get screened and evaluated for cognitive impairment may be a challenge. So what do we do then? So if someone does come to us with cognitive impairment, what kind of evaluation might they undergo? Again, this is not going to be super different than in someone who doesn't have severe mental illness. So physical exam to look for signs of Parkinsonism or stroke or other things that might be contributing to cognitive decline. Some cognitive testing. So the MOCAs kind of become the most common thing that we use these days. There are other tests out there, but the MOCA is nice in terms of being able to pick up mild cognitive impairment as well as dementia. There's some lab tests that we may do over time, or actually as part of that initial evaluation to rule out things that could be contributing to cognitive impairment, like kidney problems, electrolyte disturbance, like low sodium, their thyroid might be off. Various vitamin levels might be off. So that's all part of our baseline evaluation of someone with cognitive impairment. We'll typically do some sort of neuroimaging. So that's really to look for stroke or to see if there are particular parts of the brain that have shrunk or atrophied more than other parts of the brain. And that can be a CAT scan or MRI. And there might be some other specific things. So there's a lot of undiagnosed and untreated sleep apnea out there. So sleep apnea is a condition where when you sleep, you lie back, your airway closes, you don't get enough oxygen, you have to wake up, fall asleep, your airway closes, the cycle starts over again. So you don't get good sleep and you have low oxygen levels at night. So that's not good. It's not good for memory. It's not good for your heart. It's not good for mood. It's not good for energy. So a lot of folks out there with sleep apnea. And if you have severe mental illness, you're at higher risk of having sleep apnea. So I often am referring people for sleep studies. And then finally, in more complicated situations, we may do a much more detailed type of memory assessment called neuropsychological testing that goes into greater detail. So again, this eval is not super different than what we might see in younger adults. I do want to have sort of a quick note here on suicide. So suicide is kind of one of the most tragic and often addressable, avoidable outcomes of chronic mental illness. So for example, in older adults who die by suicide, about 90% had depression in the time leading up to their suicide. And depression is a very treatable condition, suggesting that with appropriate screening and identification and treatment, we could actually help prevent a number of suicides. This is a graph that shows you the risk of suicide in the United States by age and by gender. So the men are in blue, the women are in red, the ages are across the x-axis. You can see at all ages, men are more likely to die by suicide than women. Women are more likely to attempt, men are more likely to die. For women, the peak is in middle age, and then kind of declines, although never goes to zero. For men, there's a midlife peak. That's sort of that deaths of despair idea. And then it really takes off after 65. So a marked increase in suicide risk that's not really kind of fully understood, with one exception. So guns play a significant role in this. So men at all ages are most likely to die by gun. Older men, 80% who die by suicide, it was a firearm that they used. And for women, younger women, it's overdose first, gun second. For older women, it's kind of a tie between gun and so about 38% of older women who die by suicide die by gun. So another potential public health measure in terms of ways of reducing suicide risk, and something especially relevant in older adults. Now, what's the intersection here with dementia? So there is a slight increase in risk of suicide in the period immediately after diagnosis. So kind of somewhere in that 3 to 6 month range after someone receives a diagnosis, there is an increase in risk. the risk kind of goes down after that. And that would especially be true in folks with mental illness, because bipolar disorder, schizophrenia, major depression, alcohol use disorder, all of them are associated with higher risk of suicide. So if someone has one or more of those conditions and then gets the news that they've been diagnosed with dementia, that's really a time to kind of watch them very closely and make sure that they're getting good mental health care, because it is a period of risk with respect to suicide. One issue that comes up, and I think I saw a question along the way, is kind of what about medications and what's their role in terms of cognition. And I apologize for how busy this is, but basically, if someone with mental illness then develops dementia, we do want to take a good look at that medication list and see, could some of these medications be contributing to the cognitive impairment, and maybe we could cautiously reduce or stop medications. Now, we would do that very gradually, one step at a time, to make sure we're not decompensating the underlying mental illness. But a lot of psychiatric medications do have negative effects on cognition. So benzodiazepines like Valium, Ativan, the generics of those are diazepam and lorazepam, Xanax or alprazolam. All of them can affect cognition. There are medications that block a hormone called acetylcholine. They're called anticholinergic medications. Acetylcholine is really important for attention. If you're paying attention right now, you can thank your acetylcholine and other things. And if you block acetylcholine, that's not good for attention, and that's not good for memory. And so a number of psychiatric medications and other medications have anticholinergic effects. And then there's some specific meds that have been associated with shrinkage of the brain, including antipsychotic medications and an anti-seizure medication that's also used for bipolar disorder called valproic acid or valproate. So we want to take a very good look at this medication list. There are things to guide us. There's something called the Beers list. The American Geriatric Society updates this every few years, and it covers potentially inappropriate medications. And unfortunately, a lot of psychotropic medications are on this list. And then medications that we should use with caution, and then medications where we have to be really cautious about drug-drug interactions. And lithium is the classic one there, where it can interact with things like ibuprofen, it can interact with blood pressure medications like lisinopril and diuretics and so on. So we have to be very cautious, especially as a person ages, about medications like lithium. This is getting a little bit into the weeds, but these are specific medications with anticholinergic effects. So there are a bunch on the left that definitely have anticholinergic medications and can cause some cognitive impairment. So that includes some older antidepressants called tricyclic antidepressants. It includes an SSRI called paroxetine or Paxil. It includes a common sleep remedy, diphenhydramine, which is in Benadryl and Tylenol PM. It includes medications for bladder issues like oxybutynin. So there's a long list of these medications. And these would be useful as, for clinicians, as we think about, can we lower or stop some anticholinergic medications? What are ones that we would want to target? So bottom line is, in anyone who's got chronic mental illness who has some change in cognition, behavior, personality, or functioning, we really want to be thinking about the possibility of dementia, and then go ahead and evaluate that. Okay, home stretch here. So how do we then, so now let's say we've got someone who has schizophrenia or bipolar or major depression, and they have been diagnosed with dementia. Now what? How do we address that? So again, there's going to be a lot of overlap with how we treat dementia in people who don't have severe mental illness. So we want to support activities of daily living as much as possible. Most people have a goal of wanting to stay as independent as they can be, which we want to support. There may be lifestyle modifications like diet, exercise, doing cognitively stimulating things like puzzles and games and social interactions. Once someone is diagnosed with dementia, I definitely counsel to stop, or at the very least reduce, alcohol use and other substances like cannabis, which is not so great for cognition. Certainly other illicit substances would be a problem as well. One thing that gets complicated is that folks with dementia can have things like depression, anxiety, hallucinations, agitation, delusions, and it can get a little confusing trying to sort out, well, is this the pre-existing mental illness or is this part of the dementia? And often the answer is yes, or I don't know. We sort of empirically treat it as we're not really sure what the exact causes of these symptoms, but we do have some treatments available to help people with dementia who also have agitation or hallucinations or delusions or depression or anxiety. That's a whole separate talk, but that is that's kind of a common issue that arises. We want to help caregivers out. We want to make sure that folks with who are at risk of elder abuse, that's getting addressed, addressing legal issues like advanced planning, naming your healthcare power of attorney, and other, estate planning and things like that. There may be some role for cognitive enhancing medications like donepezil or Aricept. And of course, there have been 2 recently FDA approved medications, which we'll talk about in a second. And then possibly reducing the psychotropic medications, but doing that very, very cautiously and with good psychiatric consultation, because we want to make sure we're not destabilizing the underlying mental illness. Okay, that's a lot of pills. That gets to remind me to address this issue of then what to do. So if there are concerns that the psychotropic medications might be contributing, certainly do not stop on your own, do not reduce on your own. This really needs to be done in consultation with a healthcare professional. And there are specific categories of medications that if someone came to me, for example, I would counsel we should try reducing them. And those are listed here. And for behavioral and psychological symptoms of dementia, we really try to avoid adding new medications unless absolutely necessary. Because again, often people are already on a lot of medications and we don't necessarily want to be adding yet more medications. We don't know much about how helpful cognitive enhancers are in people with dementia who have severe mental illness. So that applies to the cholinesterase inhibitors like donepezil or Aricept, galantamine, rivastigmine. Memantine or Namenda has been looked at people with schizophrenia or looked in people with schizophrenia and might be helpful. And then we just don't know about the new monoclonal antibodies. So aducanumab and now lecanemab are available. In the trials for those medications, people with severe mental illness or alcohol use were excluded. And so we just don't know. We don't know about safety. We don't know about efficacy. So hopefully in the future, we'll have kind of more inclusive studies where we'll have a better idea about what role these new treatments might play in people with dementia and severe mental illness. It isn't just all about meds. For many psychiatric conditions, psychotherapy is as good as or even preferred. Like for mild depression, it's really psychotherapy rather than medications are the treatment of choice. So psychotherapy is a very important part of the treatment plan of anybody with mental illness. It might need to be modified, though, because if you have cognitive impairment, you may not be able to learn as well. You may need more repetitions of the material and so on. And there might be a role for things like peer support and technology to be helpful here as well. I'm going to close a little bit with kind of being inclusive in our care of people with severe mental illness who develop dementia. I've been trying to be very conscientious about using person-first language. So rather than a schizophrenic, a person with schizophrenia, rather than an alcoholic, a person with alcohol use disorder, rather than a demented person, a person living with dementia. The idea is that the person is not their illness. They have an illness, but that is not their entire identity. And so we want to use this kind of person-first language, person-centered language. Also, I really try to avoid using any judgmental or stigmatizing language like this person's being manipulative or willful or they're doing this on purpose to me. Odds are they're not. It's part of a combination of mental illness and dementia. And there's some great resources out there. There's this NIA website that covers talking with older patients about sensitive issues. I would add on, there's sort of a layer of ageism as well, which I won't have time to get into. But so, if you are an ethnic or racial minority who has schizophrenia and now has dementia and you're getting older, you've got all kinds of potential barriers to face in terms of stigma and structural racism and ageism and all the rest of it. So it's important to recognize that kind of intersectionality. There are great tools out there to help us as clinicians sort through these things. The American Psychiatric Association has something called the Cultural Formulation Interview, which is a way for me and other clinicians to interview people to sort of get an understanding about their cultural background and their identity and what's important to them. Is it their race or ethnicity or their religion or their LGBTQ status or whatever it might be? We sort of go in kind of in an open-ended, curious kind of way to understand their background. We don't know a ton about LGBTQ, older adults, and dementia and chronic illness. So it's sort of three intersections there. We do know, of course, that we want to be sensitive and respectful. This is a significant issue, especially with married or partnered LGBTQ older adults, and ensuring that they're getting appropriate caregiver supports and services, especially if someone is moving into an assisted living facility or nursing facility, having good policies in place to allow for sensitive care of sexual and gender minorities and supporting their partners as well. And of course, thinking about pronouns as well. I'm going to close with trauma. So unfortunately, 90% of older adults have been exposed to some sort of trauma. Trauma doesn't necessarily mean someone's going to develop mental illness. Some people do develop post-traumatic stress disorders. Some do develop depression, anxiety, alcohol use disorder, et cetera. There is a link between PTSD and dementia. So people with PTSD are more likely to develop dementia than people without PTSD or post-traumatic stress disorder. The point in providing trauma-informed care is we don't necessarily know. There's a safe bet that an older adult we're working with has experienced some sort of trauma in their lives, but we may not know the details of that. And so there are just some general kind of rules of thumb around trauma-informed care. So doing what we just did now, realizing the widespread impact of trauma, recognizing some of the signs of trauma. So that may show up as mistrust or people being cautious in their relationship with others, or maybe not wanting to get evaluated because of bad experiences that they've had before. Respond by incorporating knowledge about trauma into our practices, and then resist re-traumatizing people. So avoid doing things that might trigger or bring these traumatic memories back for folks, unless it's in the context of therapy. In psychotherapy, that is done intentionally in a very supportive setting as an evidence-based treatment for post-traumatic stress disorder. These are just some of the general principles here. We want to ensure psychological safety, be trustworthy, open, and transparent with folks who've experienced trauma, be collaborative in decision making. A lot of this is just like good, like person-centered medical care, essentially, and then ultimately empowering people to support their resilience. I have one final thing I'll close on. So if you have cognitive impairment or you have a loved one with cognitive impairment and you want to raise that as a concern with healthcare professionals, what are some of the, what can you do? And so I present a framework here for how to frame this to a healthcare professional. So start by describing the situation concisely, then expressing your specific concern about the situation, asserting what you or your loved one might need, and then reinforcing that a positive outcome would really be good for everyone, including you, your loved one, the healthcare professional, by appropriately responding to the concern. So I borrow this from some interpersonal effectiveness skills that we use in some forms of psychotherapy with our patients. So it's a mnemonic called Dear Man, and this is the dear part of it: describe, express, assert, and reinforce. Okay, so the bottom line here is that people with mental illness who develop dementia really need comprehensive, culturally sensitive, and trauma-informed management of this complex intersection of conditions. So thank you. I apologize for running 3 minutes over. That leaves us 12 minutes for questions. And I saw a lot. I lost track of it, so that's why I stopped answering along the way. So I saw a lot in there. So I'm happy to answer your questions.
Yeah, okay. Well, listen, Dr. Wallachek, you are definitely a favorite presenter because of your high level of expertise, your high level of compassion, your empathy, the whole ball of wax. So thank you so much for being with us today. And before we go into the questions, there are a lot of them. I want to just take a minute to thank our sponsors and have everyone save the date for next month's webinar. So thank you to our esteemed sponsors, O'Connor Mortuary, Care Choices, Hospice and Palliative Services, Caring Companions at Home, and of course, Alzheimer's Orange County. And please do save the date for next month's topic, which is the other dementias, a look under the dementia umbrella, scheduled for May 9th. And our speaker is Dr. Brian Hitt from UCI Health. So with that, let me go into the chat. And I do know that you did get some of these answered along the way. So I'm going to quickly try to sort through these. And everyone, please be aware if we don't get to all the questions today, which is very likely, that you have in front of you Dr. Woloschek's contact information, and you can email him. Okay, so I'm taking a deep breath here before we do that deep dive. Okay, what is the percentage of how many persons living with schizophrenia smoke?
It's about 90%. Yeah, the vast majority, and they often smoke very, very heavily.
Okay, thank you. Can you please differentiate mid to late life onset of schizophrenia and Lewy body disease?
Yeah, that's a great question. So that gets to that idea I'd raised earlier of sometimes people with dementia have psychiatric symptoms, and then it can be hard to sort out, like, well, is this dementia? Is this the pre-existing illness? So if someone in midlife or later life presented with new onset psychotic symptoms, hallucinations, hearing or seeing things that aren't there, delusions, believing things that aren't real, both of those would be in the possibilities. Could it be a late onset or very late onset schizophrenia, or could it be with Lewy body? Could it be Lewy body disease? Lewy body disease has other things going along with it. So it has Parkinsonism. Parkinsonism it could be Parkinson's disease, or it could look like Parkinson's. So you have tremor, you have difficulty walking, you may have trouble with your blood pressure, decreased facial expression, just general slowing down of movements. So that plus hallucinations or delusions would get us thinking about Lewy body disease. It's complicated though, because like antipsychotic medication, so if someone is on an antipsychotic, they can make you look Parkinsonian too. So that can be a difficult thing to tease out. In Lewy body disease, folks have these fluctuations in cognition. They can almost look delirious, like 1 hour they're pretty clear, and then that evening they're really confused. And it could be a sundowning thing, but not necessarily. You tend not to have that in schizophrenia. So that could be a distinguishing point. The response to antipsychotics is critical. So someone came in not on antipsychotic, and we're like, okay, well, let's start an antipsychotic and see what happens. And then they got super Parkinsonian. That would really raise the possibility that in fact it's dementia with Lewy body rather than schizophrenia.
Thank you, doctor. Okay. We're in Orange County here, and the Orange County Older Adult Behavioral Health Council has developed and submitted a pilot project to develop an integrated health and social services program for homeless older adults with a primary diagnosis of a mental health condition and a primary diagnosis of a neurocognitive disorder. The federal government does not recognize the comorbidity of these as a primary diagnosis. Your information is fascinating. Do you know of other programs that treat or fund both primary diagnoses, housing included, of course?
Well,
so this
what
could
an
be
outstanding idea. And that's something I completely missed in this talk, which is homelessness. I also missed another population, incarcerated older adults, or older adults who are in the legal system. Massive increase in the number of older adults who are incarcerated. And that's another huge unmet need. A lot of mental illness in that population and a lot of dementia in that population, and certainly in the homeless population. So a significant number of people who do not who are undomiciled have severe mental illness. So that is a brilliant idea. I don't know of any other kind of resources specifically addressing that. So I look forward to your work. I hope you get it funded and look forward to the outcomes of that. That's a brilliant idea.
Thank you. It seems that, let's see, someone's quoting an article. It seems that the early life depression has been shown to have a twofold or greater risk to dementia, and that late life depression is more of the chicken or egg symptom of dementia and not as known to be risk associated. So can you speak briefly to the early depression?
Yeah, no, that's a great clarification. And I guess I touched on that a little bit earlier, that it's possible what's going on with late onset depression is that that's really a prodrome. It's sort of the first sign that something's going wrong. So it isn't exactly that depression is a risk for dementia, but they're very tightly linked to each other, very highly associated. You know, half will have dementia in 5 years. I mean, that's a staggering figure. If you think about a quarter of people over 85 have dementia. In that population who newly diagnosed depression, half will actually end up with dementia in 5 years. The younger population, you know, the theory, you know, there's smoking, there's alcohol, there's the, you know, less exercise, less healthy eating habits. I did see a question about are SSRIs linked to dementia. As far as we know, no. So it's probably not so much medications, unless there's a lot of comorbid anxiety, and then people are on benzodiazepines like Xanax and Valium, which could contribute to the dementia risk. Some people with depression have kind of a neuroinflammatory process going on. And so that may be, I mean, I'm speculating here, but that might be a link to dementia. Some people with severe depression have smaller hippocampi. Those are the two little seahorse-shaped organs in the middle of our brain that are very important for memory formation. Some people with depression have smaller hippocampi than people without depression. And so maybe that's a link. There's an actual like neuroanatomic link to later development of dementia. So it's probably a variety of factors.
Okay. Thank you, Dr. Woloshek. I have a quick question about the use of lithium. I have a patient who doesn't have any mental health disorders, but does have an MCI diagnosis, and her psychiatrist is treating her with a low dose of lithium. Any thoughts about that?
There's no evidence to support that. I'm just to be very blunt.
Thank you. Thank you so much.
I'm not saying they should stop it. They should talk to their healthcare provider. Perhaps that person has some evidence that I'm not aware of, but outside of bipolar disorder, there's no evidence to support that taking medicinal lithium, even at low doses, has any protective effect or treatment effect with respect to dementia.
Good to know. Thank you. Oh, this is a tough question. It's about non-compliance. What do you do when a person won't take their meds that the doctor says they need? They stop taking them, and then they go out of control.
That's a tough one. I mean, that's
we need a whole webinar on that one.
Right. I mean, and it's, you know, it's not just specific to mental illness either. I mean, people with high blood pressure don't take their meds. And, you know, if you have pneumonia and you're prescribed a week-long course of antibiotics, you may only take 2 days. So, but certainly people with severe mental illness are at higher risk for not adherence to medications. And then if you have dementia and cognitive issues, that further increases the risk. So I would say, I mean, there are a lot of different answers to this. I would say that a lot of what we do in mental health, and actually in the substance use field as well, is motivational interviewing and enhancement. So trying to understand from a person's perspective, like, you know, open-ended questions. So tell me more about why you don't want to take the medication. You know, what do you think is the downsides of being on the medication? What might be an upside of being on you know, et cetera. And doing a lot of like non-judgmental, affirming, I understand, I appreciate where you're coming from. And it may take multiple efforts to get to that point of having someone adhere. Now, if it's more of a cognitive issue, then that gets to more things like, you know, setting up weekly pill trays, having a family member help out, having the pharmacy, bubble package, the Medicaid, et cetera, et cetera. So there may be more like logistical strategies. They're like machines that you can get that then, you know, an alarm goes off and it dispenses the pills that you need at the particular time. So it probably depends a bit on like what the root cause is of the non-adherence to medication.
Great. Thank you so much, Dr. Woloshek. And unfortunately, we're going to have to cut off the questions now, even though there's quite a few still in the chat box. But as I mentioned, you can contact Dr. Woloshek and he will return your email when he has time And we want to thank you so much again for your expertise and your compassion. It was just a fantastic presentation. Everybody keep that date in mind for next month's webinar, and know that you can go to our website for additional presentations, for videos of previous webinars, www.alzoc.org. And thank you all for being here. As we close this webinar, give it a few minutes, just give it a minute. The evaluation survey will pop up, and you'll go ahead and answer that in compliance with your CE requirements. Thank you all for being here, and you're getting lots of shout outs in the chat box, Dr. Welishek, and lots of feedback and comments on how much people enjoy the presentation. So we know you have to get to your next appointment. So thanks again for being with us. Thanks to our audience for being here, and we'll see you next month. Thank you so much.
Thank you all very much. Thanks for your interest in this topic.